Hi, thanks. I'm just struggling with Wi-Fi, so I'm reluctant to put on the video because it might interfere with the talk, and I just can't upload the slides. I've been struggling for most of the night, but I think the audience will appreciate it since I've got a face only a mother could love. But despite that, I would like to thank the organisers for the opportunity to give this talk, and especially CIPLA for their sponsorship of the presentation. The COVID-19 pandemic has had a substantial effect on surgeons and patients who require surgical care. Providing care for patients with surgical disease requires a unique and intimate relationship between surgeon and patient. This interaction, I believe, cannot be replaced for most by telehealth. We are all aware that operating on patients with either asymptomatic or symptomatic COVID-19 increases morbidity and mortality. In case-controlled analysis from Italy, Doglietta et al. Showed that the 30-day risk of mortality for patients with COVID-19 was significantly higher, as were the odds for perioperative pulmonary complications. The precaution of preoperative testing, adequate protection of the surgical team and patients alike are well known, and I won't go into those issues. I believe the major challenge for surgery has been the need to effectively stop non-urgent and non-emergency surgery during the waves of infection and how this has impacted on the health of many patients. The impact of the pandemic on surgery has been enormous and has affected a multitude of different areas. These include how to restructure how personnel are deployed at times of peak infections to help with the care of the COVID patients, restructuring of registrar training, and to provide a comprehensive surgical service whilst minimizing risk to non-infected patients and other healthcare professionals. The financial implications of the surgical shutdown have been far-reaching. Many staff have been affected by pay cuts, furloughs, and layoffs. Some private practices could not bear the financial challenges, and this resulted in closures. Several practitioners have taken either early retirement or have left the profession. Another major impact has been the effect on research and career development, with slowing down or stoppage of clinical trials. The impact of the pandemic on the long-term effect of patients with surgical diseases has yet to be fully realized. There's been a significant disparity between male and female healthcare providers with children, with the female parents shouldering more of the home care of the children, especially with schools being closed. I would like to focus on the effects of the pandemic had on delays in screening and elective surgeries, resulting in increased complications and even mortality. I hope this will stimulate some discussion by those in the private sector if we could have done better in this sphere by having more input with management of private institutions. Some very interesting outcomes have been shown with regards to my interest in colorectal cancer due to the COVID-19 pandemic. In response to the pandemic, Centers for Medicare and Medicaid Services recommended that all non-urgent surgical procedures be delayed, including screening colonoscopies. This resulted in a 90% decline in screenings and a 32% decrease in new colorectal cancer diagnoses. Also noted was a decrease of 53% in colorectal cancer surgeries. A study by Rachel Isker dealing with the model-based estimation of colorectal cancer screening and outcomes during the pandemic by expanding fecal immunochemical screening testing. The conclusion suggested that the increased use of fecal immunochemical tests during the pandemic was associated with an increased colorectal cancer screening participation and more colorectal cancer diagnoses at earlier stages. If this is borne out in real-world clinical practice, the use of these tests could mitigate the consequences of reduced screening rates for during the pandemic for colorectal cancer outcomes. Many have predicted that lockdowns and restrictions to attempt to contain the COVID-19 pandemic would lead to delays in both diagnosis and treatment of cancer, which in turn would result in poorer outcomes. There is now data to show that this might indeed be the case. A study from France involving patients with metastatic colorectal cancers who participated in the Panarox phase 2 clinical trial. Patients were stratified by RAS and BRAF status, determined from circulating tumor DNA analysis. The current study looked again at circulating DNA concentrations and used this as a marker for tumor burden. The median DNA concentration was statistically higher in those who received their cancer diagnosis after lockdown as compared to those diagnosed before lockdown. In addition, those patients had a lower median survival of 20 months as compared to 32 months, which is a confidence level of 95%. Theodore Hong from the Mass General Cancer Center has stated that due to gastrointestinal cancers often presenting with vague, non-specific symptoms, delayed screening will very likely lead to advanced cancers and thus poorer outcomes. Norman Sharpless, director of the NCI, has stated that he's deeply concerned about this pandemic-driven delay in screening and diagnosis. His prediction is the number of excess deaths would peak in 2 years, likely sooner for colorectal cancer than for breast cancer. But both types will result in increased death rate for at least a decade to come. Once again, I would like to thank the sponsor for the opportunity to give this presentation and thank the audience for their attention. Thank you all.
Martin, thanks very much for a very interesting talk. Can I ask a really practical question? The influence of this big surgery on the risk of these patients actually developing a worse infection with COVID. Have you got any data on that? Because we're always concerned about subjecting our patients to big surgery and then them getting COVID.
You know, I think the studies that were done and that we can all poke holes in, but certainly there definitely is a risk if you're doing this and what to avoid. How big a risk it really is has varied from study to study. So when I looked at it, it was not an absolute, but certainly there is an increased risk. And how big that risk is, I'm unsure. But what I think is more interesting is why we're delaying it. And could we do better by setting up institutions almost like COVID-free hospitals? And I don't know the answer to that. And that's why, you know, the gist of the talk was how do we carry on with normal medicine in the face of this pandemic or in future pandemics? But to say definitely that and how big the risk is on operating on patients who are doing big surgeries with asymptomatic individuals is very difficult to say.
And tell me, Martin, do you insist that all your patients that are coming for big surgery now are fully vaccinated, if possible?
So it's a difficult question to answer. So I would suggest to all my patients to be vaccinated. And certainly if it's a purely elective operation, I would be very reluctant to operate on patients with that. And I explain that I do not want to take that risk of them if they're unvaccinated, and I'll refer them on to someone who would be willing to take that risk. So certainly in my practice, I won't operate on people that are unvaccinated if they've had the opportunity to be vaccinated.
Right. We have a couple of minutes, Barry. Do we carry on?
I mean, you see Martin's husband put in a statement on it I maybe agree with. He said that he only does elective surgery on vaccinated patients. The question is what to do about your emergency patients. Do you do a rapid COVID on them? Do you refer them elsewhere? The question is, we as healthcare practitioners, what are we doing to ensure that the population is vaccinated? I mean, it's a very important question to answer, and I think Martin touched on it in the fact by saying that he insists that they get vaccinated, and I think that's just a point about general surgery and just putting other people's lives at risk and all the staff's life at risk as well. What do we actually do? I know that one of the other panelists who's going to be on later won't see his gynecological patients unless they come in. If they're not vaccinated, they have to come to his rooms with a COVID test, which they have to pay at their expense. So the practical implications on a day-to-day basis for patients coming to see you. Do you see patients who are not vaccinated? That as a general surgeon or as any doctor, that becomes and then do you insist that they have a COVID test? I mean, that's become a very interesting and ethical problem that we're all facing.
I think, Barry, the corollary of that, of course, is not just protecting the patients, but protecting us healthcare workers as well, which is just as important.
No, I agree entirely. I think it's a very, very important question and we should be promulgating it, but it becomes a difficult, it's difficult to say because, can we ethically refuse to treat patients on the basis that they are not vaccinated is a difficult ethical dilemma. I personally believe that we should be demanding that everyone gets vaccinated as far as possible.
Any questions from someone else? We've got 2 minutes to go. If not, I think it may be useful.
Sorry, there's a question. So there is one question on the chat here from David Schmuckler. We have time for maybe 1 minute question. Has COVID surge study not elegantly illustrated the highest surgical risk with COVID infection? This even in asymptomatic patients up to 7 weeks post-infection. But I think that's more a statement than a thing. So I think we run out of time. So thanks very much. Thank you.
Thank you very much.